Good afternoon, everyone. This is Diana with the Community Technical Assistance. I wanted to welcome you to today's offering, Advancing Integrated Care, Primary and Behavioral Health Integration Amidst COVID-19 and Beyond. This live discussion between Dr. Salerno of the NYU McSilver Institute and Dr. Andrew Phillip from Primary Care Development Corporation in New York City we'll be discussing the implications of the COVID-19 pandemic for integrated care and the importance of not only continuing this work, but also redoubling efforts to this end. As primary care and behavioral health providers, I'm sure you know that navigating unprecedented barriers in maintaining patient access and engagement is difficult in and of itself. But as provider burnout and patient struggles in navigating the complex system play out, we certainly do want to highlight some of these efforts that you may take. Before we get started, I do want to orient you to today's event. If at any point in time during the conversation between both Dr. Salerno and Dr. Phillips, please use the chat bot feature at the very bottom of your screen to add any comments or questions throughout our offering today, and just make sure that you address it to all panelists. At this point, I want to turn it over to Dr. Salerno to get us started.
Thanks so much, Diana, and welcome everyone. It's really my pleasure to have Dr. Andrew Phillip participating in this conversation. The first 30 minutes will be basically, you're going to be watching a conversation between Dr. Phillip and I, and then the last 15 minutes, basically an opportunity for you to submit questions, although you could submit questions really throughout and also share any comments that you have. So I'm going to let Dr. Phillip introduce himself, give us a little bit of his background, and then we'll begin.
Sure. Thanks, Dr. Salerno and Diana and everyone for joining us today. So my name is Andrew Phillip. As Dr. Salerno mentioned, I'm a clinical health psychologist by training, and I'm the Senior Director for Clinical and Population Health here in New York City at the Primary Care Development Corporation, which is a national nonprofit, and we transform primary care through investing, through advocacy, and also through training and technical assistance. Real brief, my background is, clinically working as a behavioral health provider within different types of medical settings and bringing those principles in. So things like primary care, but also trauma, palliative care, hospital-based care and outpatient specialty clinics. And I did this within large systems like Veterans Affairs and worked as a primary care behavioral health trainer for the Department of Defense. And then later got into community-based care, working with National Council, and now here at Primary Care Development Corporation, and partnering with folks like McSilver, and you also, that's a little bit about my background, but it's always kind of in that sort of domain of behavioral health meeting medical care as well.
Terrific, thank you so much. And I actually got to meet Dr. Phillip in our work together at the National Council for Behavioral Health. We were working on a national SAMHSA project related to integrated care. So that's going to be really our focus today. And so, Dr. Phillip, first of all, let's see if we can get a better understanding so that the audience has an understanding of what are we really talking about when we talk about integrated care, and why is that really an important thing?
This is a good question. I think it's sometimes deceptively simple, and we throw around the term integration all the time, or at least increasingly frequently. So really, like at a very fundamental level, when we're talking about integration, we're talking about kind of the joining together of forces around the patient. I always think of it as almost like a circle. When we talk about patient-centered care, and this is a very literal way of putting it. So sort of the patient or a defined patient population is kind of at the center and the focus, and we strategically around the patient or the patient population build in other supports. So we have primary care clinicians, we have behavioral health providers, and then we also have some continuity around usually social service and social needs as well. So taking that kind of bio-psycho-social approach, if you will. And what that actually looks like concretely, it varies a lot. So sometimes we talk about bidirectional integration or integrating behavioral health into a traditional kind of primary care service, or the opposite, right? Bringing behavioral health, or rather primary care, into behavioral health. And there's different models that support this. There's the collaborative care model, which is synonymous with the AIM Center. There's the primary care behavioral health model, which is much more focused on that kind of bringing into primary care aspect. And now, more recently, we have blended models. But that kind of foundation of joining together of services in one place at the point of service that more fully meet the patient's needs is really kind of the cornerstone of integrated care.
You know, when I think of it, it sort of makes like a lot of sense, right? To kind of treat everyone one in a holistic kind of way, and sort of recognizing the interdependence of, you know, your physical health, how that affects your emotional health, how your emotional well-being affects your physical health, how substance use can affect both. And, you know, it's like these things are not really separated so much, but yet our system seems to be separated. When I think about the healthcare I get, it's really, I have to say, right now it's disintegrated. You know, where I get care is, you know, if I had a substance use issue, it wouldn't be going to the same place where I get my primary care or specialty care, and mental health would be like separate from that. And it's kind of like, why is it that we haven't really kind of moved in that direction?
Right.
And that it's like this big innovation, and not so easy to do. What was that about?
Yeah, I think that's a good question, right? We have a lot of good reasons to kind of keep things as they have been and as they've been working, you know, seemingly well. And when we look at sort of how the system has been, you know, there's some things that we have to take notice of, right? A lot of good has happened. We've kind of transitioned people out of sort of almost like a criminal justice kind of model of providing services. You know, we've destigmatized in many ways behavioral health services. And then, you know, more broadly, you know, we're reaching more people by doing this. But in the process of this, we've also, I think, had a few significant losses. And in particular, what that looks like is wait times. So I think any of us who have tried to seek behavioral health services have probably been met with some of the difficulties in accessing these. And so that can be in terms of, you know, once you do get a referral, it could be 3-6 months long because there's a huge issue around carrying caseloads and sort of, you know, I have this defined set of, you know, 50 or 60 people I serve. And once I have them in my kind of net, I don't have space for more. And if I keep people for years at a time, there's a real kind of critical mass that builds. And it's hard to move beyond that and get new people in for services, especially if they don't require, you know, years and years of treatment. We also have significant issues around burnout. And that's not only in behavioral health, but also in primary care. So we have staff who have been kind of working as really the sort of prime mover of healthcare and focusing on as sort of trying to meet all of their patients' needs. And that's really hard and that's stressful and frankly exhausting. So we have issues around burnout. We have issues on the patient side around access to care. And then we also have shifting demands as far as the payment and regulatory environment. Here in New York State, we just finished our most recent round of the delivery system, DSRIP, the system reform effort. And there was a really nice push for and a call for integrating primary care and behavioral health together. And so these are sort of traditional way of doing things, of providing care in sort of one existing silo, is really being challenged. And I think that's part of what brings us all here together. It's both the forces from our patients, from our providers, and from our systems, kind of all coming together right now.
You know, when you and I were working together on the integration efforts, one of the challenges that came up over and over again is that, you know, the way, the kind of culture of primary care and general health care, and then the sort of way we do things in behavioral health, or at least in mental health, and then the way folks do things in substance use. And there's always this kind of tension and challenges. How are we going to bring all these people together? Because, you know, what you're talking about is like a team-based kind of like care, right? That, you know, especially for folks with the most complex kinds of challenges. And yeah, they need everyone to kind of coordinate care and collaborate together and all these sorts of things. And yet at the same time, it's like, there's so many different, you know, trying to bring folks with different ways of their thinking of their roles, of their training, the pace of their work, and letting them all kind of figure it out as a team. That team seems to be like a really difficult thing. And, you know, what challenges do we anticipate trying to make that happen in the future?
Another good point. And so every time we work with pretty much any system I've worked with, whether you have, and this kind of goes back to that sort of what model of integrated care are we talking about, but whether we're joining together like multiple pre-existing organizations, so let's say a sort of community-based behavioral health organization and a federally qualified health center or a primary care centric organization, or even when it's one organization, but we're sort of modernizing or moving towards a more integrated framework, there's usually pretty significant cultural clashes. And so by that, I mean, things like, who do I consider to be my patients, right? And particularly I see that a lot when we're talking about like folks with serious mental illnesses and persistent mental or emotional disturbances. Even our regulations kind of inspire some cultural conflicts there, saying that, for this patient population, we have to have a separate waiting room over here or a separate sort of intake process here versus for, our more primary care center population. And then also understanding where are my boundaries as a professional, right? So where do I draw the line between saying this is my patient and this is your patient that I'm just consulting on? So if I'm a behavioral health, not very concretely, right? If I'm sort of behavioral health provider and we're working together on a patient who has both physical and behavioral health needs, is that patient kind of owned by the PCP, the primary care provider, or are they owned by behavioral health? We're not often used to sort of sharing our patients and the ultimate responsibility for them. And that extends into other places as well, understanding what are the, for a behavioral health provider specifically thinking, like what are the outer limits of my scope of practice? As we're encouraging people to consider, the behavioral health as well as physical health needs of patients, it brings up fundamental questions for us, right? Like what are sort of what can I say is within my ability to practice? What did I go to school for? Do I know how to talk about diabetes or hypertension if I'm a behavioral health provider? And on the flip side of that, we know that a lot of primary care providers don't really receive much training around mental health or psychiatry specific emphases. And they don't necessarily feel comfortable, asking about things like substance use disorders, around suicide and mental health conditions. So it's really from both sides.
This is going to be conceptually, it sounds like, oh, it should be a piece of cake, right? It's just, we should just treat the person at whatever level of needs that they have across mental health or, physical health. And folks come together to kind of coordinate their care and all that kind of thing. But when it comes to actual practice and what the implications are, it's pretty big. In fact, we have a question actually from Michael Matthews. And thanks so much, Michael, for sharing the question. And this is a really important one and really much related to what's happened now with COVID-19 is, how do you see the impact of telehealth? Now that telehealth has exploded because of what's happened during this crisis. And what you think how it's going to relate and its impact on the future of integrated care. Have any thoughts on that, Dr. Phillip?
Yeah, man, if there's ever been an interesting topic happening in healthcare right now, of course, COVID is really, first of all, more largely a tragedy in a lot of ways from, both personally for a lot of folks and also systemically and some of the implications for our society. But telehealth is one interesting, area that's really come to the forefront in this. And I think initially it was really viewed and experienced as a major challenge. How do we take systems and providers who, were already really, like telehealth was still for most people, either something that we kind of dabble in or still pretty far off from making this routine. And so now, it's sort of become particularly for behavioral health, but also for others, like as we've kind of closed non-essential access to services, it's become a mandate really. And so we've suddenly seen an opening, at least temporarily, and I think more lasting as the days go on, of reimbursement for telehealth. But the practice implications are also really interesting. So, on the upside, what we're seeing is we have a new relationship with our patients, and I think it's particularly interesting when we think about children and families, because now we can see the environment in which an individual is living. We can, we oftentimes will, I hear a lot of stories from colleagues who are treating children and particularly working within schools. And what we're seeing is just you may have the child kind of there on camera with you, but just behind the camera is the parent or is the guardian, and they're sort of, either hovering or sort of, doing something else in the background, but it's an opportunity to bring them in and to kind of incorporate them in discussions. And also, there's more sort of presence for things like safety planning and stuff like that. But there's also challenges around telehealth, and it's becoming professionally comfortable with some of the obstacles. So what do you do when you're having a conversation with someone about, let's say, trauma, and suddenly the video is glitchy or there's noise in the background? You constantly ask them what they just said. It can be a challenge therapeutically. And then, of course, it also brings, bandwidth limitations and things like that. So there's a lot going on there. And I think the push right now is figuring out, particularly with integrated care, how do we routinize this and systemize it so that, for example, if I'm trying to conduct a handoff between primary care and behavioral health or other providers within sort of now a virtual clinic, how do I know who's available? How do I sort of make that transition seamlessly? How do we make sure that the patient's not lost in that transition? How do we communicate with each other professionally within the clinic? Since we're not sort of there to just, tap on the door and do a quick drive-by. So it's, I think from the user perspective, our patients are having unprecedented access. Initially, we saw quite a dip in productivity and the number of visits. And now, and really since April and moving into May, a lot of clinics are reporting that they're actually seeing spikes or even higher than pre-COVID levels of patient engagement. And much of that is because patients are, one, they're dealing with the effects of COVID, but they're also able to access care in a way that for many is much more comfortable. But there's peculiarities to all of them.
Yeah, I mean, I think in many ways, as you're saying, is we're gonna have to kind of figure this out. If you have a team-based approach, would you literally have 2 or 3 team members with the client on a Zoom call, and each person, who may be addressing various aspects of the person's life? Do you have one person who kind of represents the team to kind of like share what the recommendations are and all? And when you're having interviews, it's, how do you work that all out? I think that's difficult. That's a challenge, even in face-to-face. But I think we're not really quite sure how this is all going to work out, because people are still trying to figure out, what integrated care is about, right? And those relationships and all. So that, I think, is likely to be the case. Now, in looking at something like COVID-19, is there a sense that what we've noticed in so many people, the emotional impact this is going to have on so many individuals, and it reveals the relationship between physical health challenges and also increase in substance use kinds of issues, increase in depression or anxiety. Do you get a sense of whether that's going to accelerate, our move towards a more integrated system, or is it going to decelerate it, or likely to kind of not sure where it's going to go? Do you have any thoughts on that?
Yeah, and I think there's a lot there, and so I'll try to give sort of my highest level overview. Absolutely, right. So I think we're all concerned about, the emotional impacts of COVID, right? The isolation, as you mentioned, increases or potential exacerbations around substance use disorders. There's a lot of buzz around intimate partner violence and some of the concerns there, as we have people who are sort of clustered together without easy escapes into the rest of the world. And just loneliness and sadness, the anxiety, dealing with uncertainty. And so there is this certainly huge potential for need around behavioral health. And then we also know that those things are exacerbated and contributing to and kind of interfacing with the physical needs, right? So what I'm concerned about is that, and I think across primary care and behavioral health as well, is that people are putting off their usual preventative care. This is not a moment where, for example, someone with who's kind of moving towards being diagnosed with diabetes is getting that early A1C check, or, their blood sugar monitored, standard labs are being put off. So there's concerns there. And then also from frankly, a sustainability perspective, both primary care and behavioral health clinics are in an awkward place, and frankly, a really difficult place just to keep the doors open because of the fluctuations in patient volume and also just navigating all the change right now. So I think there's an opportunity in COVID, and what I predict is going to happen is that we're going to see actually greater levels of integrated care. Part of that is because we're seeing an increase in the demand for behavioral health services more broadly, and that's both with our traditional patients, but also with our providers and recognizing provider health needs. But also now more than ever, whatever point of service someone is getting care at, whether it's with their primary care office, whether it's with their behavioral health provider, their chiropractor, whomever, it's more likely now that that's going to be their only access to care than it was before. And so it's I think the need for bringing services together from the patient service perspective is higher because of both the acuity of physical health concerns, the impact of delayed care on physical health, and also the increase in behavioral health needs. But from a business perspective, from kind of a viability of a business model perspective and how we deliver care, as both primary care and behavioral health, they're kind of struggling to push through this. There's going to be, I think, a greater incentive to bring services together, to kind of merge, in some ways just out of survival, as well as just doing the right thing for better care. So there's two sort of factors that I think are independently working. They're going to bring us closer towards a more integrated system of care. What that looks like, I suspect, will vary greatly. But that kind of idea of we need to bring more services to wherever the individual is coming for them, that's going to be, I think, a universal.
Great. Thanks so much. Let me just reach out to the audience. Please type in the chat box any comments you have, any reflections, any ideas you have based on what Dr. Phillip is saying, and of course any questions that you have. Just please type those in. Terrific. Here's an interesting sort of question around do you think that face-to-face model will return? I kind of find that interesting because one of the things I found is my son-in-law happens to be a psychiatrist in a federally qualified health center. And so he's, everything is through basically the phone, or for those who do have a video capacity. But productivity has skyrocketed. It's like the number of no-shows has like decreased tremendously. The need out there, the degree to which people expressing anxiety and depression is like really increasing, and a good number of folks saying that they prefer the virtual kind of approach. It's like less demands on them. So this is kind of an interesting question. Will we come back to face-to-face model, or they're going to be a hybrid, maybe a model, or is it going to be based on the client's preferences? Any thoughts on how this new normal might impact healthcare, both primary, integrated, behavioral health? Any thoughts on that?
Yeah, I think it depends really on what we're talking about, right? I do not on any level think that sort of the existing need for face-to-face in-person services has now disappeared because we've figured out how to use Zoom better. But that is it will become more normal, right? I haven't heard from anyone on any national call, on any city or state calls or discussions. I have not heard anyone really saying, "Gosh, I can't wait to get rid of telehealth. This is just awful." The patients aren't saying that, providers aren't saying that. But there are some unique circumstances. So, I think some of and I'm sure folks who are on our call right now have had some pretty interesting experiences and perspectives on this, but, like residential treatment programs, for example, intensive day treatment programs, there's certain models that are harder to kind of rig up in a way that is, solely based or conducive for virtual care. And there's also things that we just, that are part of integration and also unique and present in behavioral health, things like getting lab work done so we can monitor, a psychiatric medication and, looking at, blood levels for different medications, and also testing other risk factors. Within primary care, of course, we still have to do things like biopsies, there's technological advances that are making it more possible, but long story short, I think it will be more of a hybrid model. We're going to see people who don't want to drive all the way across town or take, 3 subways and a bus to go get care. Same thing with clinicians and staff. We've, thinking about rural areas of the state and of the country, there are often health, there are shortages in providers that we can recruit into these areas. And now we have a much greater level of flexibility also for professionals. And I think that desire to maintain that is not going to go away. And we have to do, everything we can to both meet the needs of our patients, but also the staff who work in these settings.
Terrific. We have a lot of questions coming in. It's a very thoughtful group that we have. So let me get to some of these questions. This has to do with providers utilizing health homes to enhance integration. Will health homes be able to play, at least conceptually, the way they were designed to really contribute to promoting and accelerating integration?
Absolutely, yeah. Health homes, whether we're talking about kind of lowercase health homes or uppercase, like patient-centered medical home kind of models, but that fundamental understanding that we have sort of a unified entity that is meeting the various and many needs of our patients and collaborating within that organization or system, that's still, I think, very foundational to integrated care. And so I see opportunities not only for health homes to kind of bring in this broader array of services, but also to be hubs for patient care. So kind of bringing together those referral networks. I think there's great opportunity with health homes. So, if we take like a primary care health home, to bring in connections with community behavioral health organizations, to have that kind of steady stream of referrals, and also even beaming in some of the provider types. So I think health homes, they're kind of in a lot of ways a juggernaut of our patient delivery systems, and their influence is huge here. So I think that's a great opportunity they've already been on the vanguard in many ways of integrating care. And so I think they'll continue to be in that position. I think you're on mute there.
Let me unmute. Sorry, I was muted. Thanks, Carla. Rose, for that. No, I'm sorry. It was, let me see here. Okay, so. All right, that was from Megan Cronin. From Leela McCarthy. Any issues around HIPAA and privacy issues that have risen now with telehealth? And are there HIPAA issues related to integrated, care as well?
Yeah, that's always been, I think a sore spot for a lot of us in healthcare, and even before COVID, we've had a lot of conversations around some of the regulations that govern health information, and that's been more of a topic as we've talked about health information exchanges, as we're sort of revisiting 42 CFR and some of the kind of more historical barriers around sharing certain types of health information, especially around behavioral health. And now with COVID, we've seen, what's been like very clearly labeled as a temporary lessening of the, restrictions around HIPAA, around different platforms that we can use for delivering telehealth. However, that is, from CMS and others, it's been sort of deemed as this is temporary. And so, we've been so far tasked with just figure out whatever creative way you can, basically, of accessing your patients, whether it's through FaceTime, through, Zoom platforms. But now, as we've had a moment to catch up, I think the expectation is going to be that we, move towards, very secure systems. We're going to have to do that. My fear is that if we don't catch up and if we don't modernize the technology around engaging with patients in a safe, secure way, we were already in a system that frankly was fairly fraught with issues around confidentiality breaches. We'd have you hear stories of, payers who send out like a mass mailing and the little window on the envelope, expose the name or so these were already concerns. Technology amplifies that, and we cannot risk losing the confidence of our patients and our communities. That's already been an area where, as we reduce stigma and we increase access, it's been a struggle culturally. And so this is an opportunity to increase that, and we have to really do due diligence, I think, around confidentiality and health information technology.
Terrific. Thank you. Thank you so much. Also, Carla Rose mentioned that telemental health, it's been here for years, but the reimbursement is not. And is this likely to change? And how much will changes in reimbursement and regulation likely to kind of move us more towards integrated care, or actually kind of set us back?
Yeah, it's right. So some places like think of Marlene Mayhew at like the Behavioral Health Institute. That's been around for decades, I think. So yeah, this is not like a new thing. It's just the scale is quite unprecedented. But payment is going to be, it's messy, right? We've been fighting for parity for decades at this point, and it still is not really quite there, and when we talk about incorporating codes that are more specific to integrated care, like where it's available, like health and behavior codes, thinking about like complexities around like incident to billing, how do you have reimbursement when you have two providers seeing the same patient for the same issue in the same day? There's all these complexities that have come up, and recently we've seen a very quick turnaround as far as payers go, both public and private, to reimburse for teleservices in a wider sort of definition and for a wider range of provider types. Even just this morning, I was reading something from CMS about some of the Medicare reimbursement mechanisms that are now putting in long-term reimbursement methods for telehealth, including behavioral health. However, I think it's going to be slower. It just, unfortunately, if history has taught us anything, it's going to be that reimbursement around behavioral health catches up slower. However, there's been calls for it. There was a great paper that came out from the bipartisan policy group, and they noted that as we're increasing funding around COVID and payment there, we have like the COVID codes, for example, we need to do the same thing for behavioral health because we're seeing kind of paired trajectories going. So there is more attention for this even outside of the behavioral health world. So it's going to get better, but frankly, I just think it's going to be a little behind the physical health reimbursement.
Thank you, Dr. Phillip. Dawn Adams, her comment was that many clients, are really struggling with some of the technology demands, and to what degree will that need to be taken into consideration, really, as we move forward, so this platform really works with people?
Yeah, there's, I currently offer, I'm seeing patients through telehealth myself, and I, from the field and my own experiences, I see sort of these tricky issues, right? And I think initially a lot of the concerns I heard were around, older adults, and saying, well, how, will they be able to embrace technology and will this work? And what I'm seeing the shift in conversation now to much more frequently is around those other kind of technology related issues, like I said, like dealing with like glitches. Privacy is another really big one. I have patients who are, taking our visits in the car, or, will, be engaged in a conversation about other family members, and those family members are just downstairs, with headphones on or something. So there's a lot of really specific implications of particularly the remote work that are, going to be, we're gonna have to figure these out from a practice perspective, incorporate these into graduate medical and training programs, and also, our existing resources like what's offered through CTAC. And also in rural areas, I think, and what we're seeing is, and we'll see more of this, I believe, is grants and money made available for building out the infrastructures, for building out broadband, for, we saw this in the city here with the Department of Ed, giving out technology like tablets and things like that to help meet patients where they are. At a very sort of like basic level, I think we all also just need to acknowledge that it doesn't have to be too complicated, right? We can deliver many interventions effectively through just the telephone. And then also broadening our approach, thinking about how can we use text-based communication, like, messaging back and forth, and basically meeting our patients wherever they are, right? What's their sort of technology and health literacy? What can they access, and what makes sense given the actual physical situation that they're in?
You've sort of mentioned in some of these questions related to sort of the client's experience of this and some of the challenges or the preferences that they have. But someone, Lourdes Torres, thanks Lourdes for asking this question. She says, I noticed with experiencing telehealth versus face-to-face sessions, telehealth has created exhaustion for therapists due to some of these changes. Would you say burnout may be created more within telehealth than face-to-face sessions? So that's like an important issue, is on one hand, how does it work for clients? On the other hand, to what degree is it working for practitioners? And I think that's a really important issue that was raised as well. And we may not know the answer to that, but what are your thoughts, Dr. Phillip?
I love this question. This is so interesting. And it does point to a real pain point for almost everyone in healthcare right now, and that's burnout, right? So this was already, before COVID started, we, like studies on burnout were finding about 60% of healthcare staff were experiencing some form of burnout, right? And that was before COVID. Now there's unique demands around in life for all of us, right? Which are making things more stressful. But, I have heard a lot of people, and increasingly this is becoming like a more sort of open conversation around some of the sort of exhaustion that comes from operating remotely, from interfacing specifically on video, right? There's a different level of energy that it takes to work this way. It's not the way, first of all, it's not the way a lot of us were trained, so it's not, there's not that familiarity. So there's energy that just goes into like, there's an extra cognitive load that goes into just figuring out like, how do I use this platform? The stress that comes from anything new. But then also there's unique demands around analyzing even, a person's movement. When I look at you across the screen here, I can sort of see your shoulders, I just say your fingertips for a moment, and your face and the sort of setting behind you. But I have to really make some inferences about what's going on with your body language, wondering what's there in your environment, making sure that you hear me and that I hear every word you're saying and that we didn't dip out for a moment. there's all these, and then also simultaneously interfacing with the technology interface. So there are these different components, and that's built on top of what was already there, right? We know like set switching or sort of moving between tasks, between patients, those demands continue to be in place. So, those are all kind of recipes for different types of exhaustion. Not to mention we all have families, we have lives that are all impacted by COVID. And so there's a baseline level of stress. What's encouraging to me is that, first of all, we're talking about this more, that burnout's becoming, the last few years, it's been an increasing issue. And as we've added this quadruple aim, but it's, and some of the kind of my favorite conversations are where we acknowledge this and we talk about, like, do we need to have this extra Zoom meeting today? Maybe we can, we'll skip this one or we'll go off video for this, just acknowledging that kind of fatigue. COVID's created this sort of, I hate to say like amazing, but this really interesting situation where there's a universal human experience happening. We're almost across the board all going through some level of stress, dealing with uncertainty, dealing with fear. It's universal to our patients, to our staff, with each other. And I think it's creating an opportunity to talk about this and to talk about, hey, I feel exhausted, or do you feel as drained as I feel? Do you think that this method is working for you? So, there's opportunities there. We also know that historical data around integrated care suggests that burnout decreases with integration with team-based care. We have a network of peers that we can kind of share the responsibility of caring for our patients with. And so there's opportunities there. And I think as we translate integration to these virtual platforms, that will become more evident once again.
Terrific. Thank you so much. I just want to read out a comment that Melanie Bush wanted to share with all of us. I do worry. She's worried that in the future that this may lend itself to more socially impaired individuals, having all this kind of virtual contact, particularly adolescents, as positive socialization skills, the day-to-day practice of talking face-to-face, reading body language and cues is sort of reduced the point you just made. And telehealth is wonderful, but it reduces this opportunity to work on skills, especially around those kind of maybe social, skills. And I will say that social anxiety will kind of worsen as well. So it's just, Melanie's sharing is just a concern she has, because in many ways, we don't know what the unintended consequences is of something so new. We were trying to figure out what might be some of the negative unintended consequences. And Melanie is kind of raising that for us. I wonder if you have reactions to that as well.
Yeah, I think it's a good point, and it's something that I think we're all concerned about. I think of certainly, building social skills and also just interfacing with the environment, but also, I worry about the impact on, on patients and individuals who are dealing with anxiety already, who are dealing with, things like obsessive compulsive conditions and, fears there that are certainly, this is really cranking up the volume on, and it also is presenting challenges from a treatment perspective, right? Like thinking about things like exposure-based methodologies, which are, are sort of like foundation around addressing anxiety. It's hard. We have to kind of think in new ways. Like I said, I do think I agree that, isolation, sort of staying in, staying away is going to exacerbate some of that. And we'll see a trajectory change. This is, we have children now who are growing up in this totally different environment, and there will be an impact, they'll sort of have a different perspective. But again, also, there's opportunities where we can use new tools that we didn't have access before. When I'm talking to a child or a family, I can say, hey, what's that in your background there? Or do you have anything in the house that you can use? Someone mentioned a few weeks ago, a coping tool scavenger hunt in the house, people can kind of run around and grab the things that they would use for soothing, for coping with, whatever's going on. So there's opportunities there, as I mentioned, kind of bringing in other members of the family. And then also commenting, and I do this with my patients now, commenting on the environment, saying, I hear there's a lot of noise, or you're constantly having to like shift from room to room. Is that kind of chaos? Is that stress part of your daily life? There's all this data that we didn't have access to before. So my hope is that some of that balances out, but absolutely, it's going to exacerbate some things.
Well, Dr. Phillip, this conversation has raised a lot of response from our audience, which is terrific. We have a few more minutes. Let me just kind of share this one with you and see what you think. This is from Mary Emerton. And one of the challenges for both behavioral health and primary care is going to be any furloughed staff, less resources that might occur. And how do you kind of move beyond the current fiscal challenges to continue to offer integrated care. So it's like, how much of the system has to be aligned in order for us to do it? Is it something that an individual, this is what I was thinking about when Mary wrote this, is as an individual practitioner, can I practice an integrated care approach, even in the absence of having team members? Another person had a question around, how tough it is to try to get people together, people in the health, primary care or substance, forget it, it's like very challenging. So there are these kind of barriers that exist out there. And one might be, so if you're an individual practitioner, because part of it is I don't like to give up on stuff because the system isn't so aligned or there are challenges. Is it possible for a person to have an integrated care framework, even if they don't have necessarily the other supportive infrastructure, for it to be really at an optimal level?
Yeah, absolutely. We know that there's huge financial barriers to some of the models of integrated care that we talk about we're talking about trying to just retain our current staff, let alone hiring new people and new provider types into the system. At PCDC, we invest in this area. We've invested in, building out shared systems and places to provide care, but I know that's not always an option. So yeah, I think any individual, and whether you're in the primary care, behavioral health lens or something else, we have the opportunity to sort of make our discussions with our clients, with our patients more integrated. So, even simply asking about, at the start of, let's say it's your first visit with a client, asking about, not only their social history, but also any significant medical issues that they have. Do you have, are you in pain? Do you experience any kind of daily pain? How do you cope with that? Do you have any chronic medical conditions? Is there anything else that you're taking medication for, other than your mood? And that yields really interesting conversations. We know that, and I always try to encourage everyone not to get too intimidated by talking about health conditions, because there's always, I would actually say there's pretty much always a behavioral component to it. And that's something that we are trained to do. If you tell me that you're, struggling to cope with the daily experience of pain, even if I'm not a pain expert, I can find out what is that like for you? What are you using to kind of get through that and cope with it? And then use some of my existing strategies to make that conversation more holistic. So just even asking about those types of concerns is a starting point.
Yeah, I think that's a really important point, because I know it can be frustrating. Say, I as a practitioner can't really practice holistic care unless I have a whole team behind me, that the infrastructure is in place, the financing. That, of course, is the optimal. That is what we strive for as a system. But I do think this last message you're giving is an important one, that you, and whatever is your purview with any client, if you have a mindset where you recognize the interdependency of a person's emotional well-being, their physical health, their use of substances from caffeine to tobacco, to alcohol, to anything else, right? When one has that holistic perspective, you are practicing integrated care. And nothing has changed in the system except you, as the practitioner, that you bring that perspective. That's the way I think is an important thing not to forget, because you can feel kind of hopeless or demoralized that you can't really be guided by those principles and practices of integrated care unless you have all these other kind of facilitating conditions, which may or may not appear. My sense is that's what you were kind of getting at.
Yeah, absolutely. And, again, our circumstance right now, COVID has really shown a light on that, right? There's, people are struggling to manage their chronic medical conditions. They're certainly worried about their physical health, but then they're also, they're going through I think someone I saw it pop up for a moment, that's sort of the trauma associated with COVID, the sadness, the isolation, that despair and uncertainty. These both physical and mental and behavioral health are high on everyone's mind right now. It's sort of at the surface, and there's an opportunity and I would argue if we're not asking about that, frankly, I haven't had a single patient who has not brought up COVID and concerns about COVID, but if we're not asking about physical health, we're missing a huge part of this person's context for their lives. Even if we're not the experts on, what do I exactly do with this? Even if I'm kind of Googling the diagnosis and on the side there, you can still engage with the patient in dialogue around what their experience of this is. And that's fundamentally what we do as behavioral health providers.
Well, I want to thank you, Dr. Phillip. This is terrific. We're out of time. I want to also thank the audience for having so many really insightful comments and insightful questions. It's been terrific. It looks to me like this is a topic that we could really extend. And we at CTAC will always take these questions, these comments, and then also your survey feedback on this conversation hour or 45 minutes and share that with us, because we look at it so carefully so that we're able to kind of design future programs that align with the felt need that all of you have out there. So again, thanks so much, Dr. Phillip. You've done a wonderful job. I really appreciate it. You know, the opportunity to learn from your insights. And let's see, Connor, do you have instructions for the folks regarding a survey?
So there's something pop. I'll just, as we're waiting, I'll just thank you for having me, and thanks everyone for submitting your questions and joining us, and feel free to keep in touch.
Terrific. And Connor, are you on or on mute?
This is Feng. We just sent out the survey link in the chat box. So
Okay,
click
terrific.
over there, and it should also open up if you once you close out of Zoom.
Terrific. Thanks so much. And we encourage everyone, please spend just a couple of minutes to give us some of your feedback. We really appreciate it. All right, everyone, stay safe and stay well. Bye-bye now.
Thanks, everyone.